All right, any questions from last week? Any of the pain management stuff we were covering? Questions so far? So we covered most of the meds, I believe. I think we're just talking about adverse effects right now. So frequent adverse effects to expect when you're dealing with opioids. Constipation is a huge thing. We have opioid receptors that are present on our GI tract, and when you activate those tend to slow down peristalsis. Again, do you know if you ever get tolerant to the constipating effects? Because remember, we talked about tolerance. What was tolerance? If you stay on the same dose, you're going to end up losing effect, right? You're going to kind of get more kind of used to having that drug around. So when your patients get tolerant to the analgesic effects of opioids, you have to do what to your dose? Gradually increase it. However, the constipating effects, you never really get rid of those. They only get more and more constipated. So this is why it's super important that we have these patients on a good bowel regimen. Okay, so when I say bowel regimen, we're going to talk about those in GI coming up next, I believe. And so it's really important. We'll talk about this concept of mush and push. It's a good, easy way to remember that. So mush is going to be things like our stool softeners, and then the push is going to usually be a stimulant laxative. That way they kind of get it on two different mechanisms where they're going to have that urge to defecate feel a little bit more strongly and not be so constipated. And again, we find this with a lot of our palliative care patients who are on massive doses of opioids for their pain issues. And then you're trying to figure out, like, why the heck are they just not right? It seems like they're still in a lot of pain. A lot of it has to do with abdominal issues that come about from this constipation. So always remember, never underestimate the value of a good poop, right? Okay, other things you can see commonly, sometimes patients will get some histamine release. You're going to see this more often with things like morphine and some of its derivatives. Remember what gets turned into morphine that we talked about? Yeah, codeine being the other big one. So that can cause some histamine release. You can see some flushing, itching associated with that. Not a true allergy, and that's important to remember because if you have a patient who says, oh, I have a morphine allergy, that can preclude them from use of several of these opioid medications. And so you want to make sure it's an actual true allergy and not related back to the histamine effect, right? So if someone, for instance, said, I have a histamine or I have a morphine allergy and said, oh, you have anaphylaxis, I may not want to give things that look similar to morphine. So I don't want to give codeine. I don't want to give things like hydrocodone, those semi-synthetic ones. You got to be careful with that cross-reactivity. I might need to use something like fentanyl or some of these other kind of really synthetic sort of opioids. However, they said, oh, I just had a lot of flushing and I threw up. That's not a true allergy. I could use something like hydrocodone. I could use something like hydromorphone, and that would be okay because generally those have a lot less histamine release associated with it. Now, if you gave morphine and they got really flushed and they're itching, could I give them? Use some Benadryl, right? Because they're using antihistamine for all the extra histamine they have around, right? Less frequently, you can see that some people will have like delirium associated with their opioid use. This is less frequent, but can happen. And then you want to be careful with this respiratory depression. This is the big thing that's going to kill patients if they have too much of their opioids on board. And so you have to be really careful with this. Normally, you're not going to see it with normal dosing, but you run into issues where if you have patients who are maybe self-medicating, people who are abusing these for the purposes of recreational use, people who accidentally maybe break a controlled release preparation. So, for instance, if I didn't know any better and I chewed up an extended release preparation, I get all the drug at once. That could be a risk. These are things to consider. Of course, think about risk for abuse and diversion. When I say diversion, what do you think I mean by that? Potentially giving to other people, or and what we think about a lot of times in the hospital side of things is think about actual the healthcare providers abusing the medications, right? So again, you think about like anesthesia is one of the kind of high risk groups for abusing opioids and other medications here. You worry about people stealing medications, selling them, or using them themselves. There have been stories of either doctors or nurses being found back in a patient's room or something. It was empty and they're abusing the stuff and they're found dead basically. And so there's lots of cases where you have to be careful with this. We, from the pharmacy standpoint, and usually in a hospital, you'll have like a diversion policy set up. You'll have like a diversion group that is set up to look at kind of abnormal uses of opioids. So, for instance, if you had one nurse who is always going to the Pyxis to get, or the machine that dispenses out the medications, they're always the one going to get the morphine, and it's like way higher use than all the other nurses, that could be a sign of diversion. It could be that they're either using it themselves or selling it, things like that. So these are things we have to consider as being a risk for healthcare providers, right? So we ourselves are not immune to this sort of thing. Abuse, again, just someone using it for non-intended medical indications there. So it's important to consider that sort of thing. So to try to minimize the adverse effects, we can try to titrate gradually. So again, you don't have to go balls to the wall, super high doses immediately. Start low dose. Try to, you can always give more. You can't take it back usually once you've given it. Try to determine what the cause of their symptoms is. Is it histamine release that's causing a lot of their nausea, vomiting associated with, their morphine use? Maybe we could switch to a different medication. Things like that. In some cases, we can try to switch to a different opioid. Sometimes we can try to treat through the adverse effect by giving something like Benadryl. So there's lots of different methods here. But again, remember that mush and push is being really important for the bowel regimens for these patients. So in general, they're going to be on chronic opioids. They need to be on a bowel regimen as well. It's going to be kind of one of those things that needs to be a package deal, because otherwise you're definitely going to run into that constipation issue, and it's going to be a big complaint for them. Okay. Other things we can do to try to help is, get them plenty of fiber and fluid, but oftentimes this is not going to be enough to help fix that. So we need to do something like use a combination of stool softener and stimulant. So this is where you get like Senecont that has, and we'll cover these more in the GI section in a second here, but includes Sena, which is a stimulant, plus Docusate, which is going to be one of our stool softeners. And you guys have heard of a lot of the laxatives in Dr. McClary's lectures on GI, correct? Or you cover some of them. So we'll talk about these more in detail in just a little bit. You may need to include things like, Miralax and other kind of osmotic laxatives, but we'll talk about these more in detail. Now, as far as an antagonist, if you need to reverse someone's opioid effects, we talked about one big one during my intranasal lecture on Friday, which was what? And naloxone. There's lots of different ways we can give this, and it basically works as an opioid receptor antagonist. It's basically going to kick the opioid off the receptor and reverse all those effects pretty much immediately for the most part. Lots of different ways we can give this one. So I mentioned intranasally, obviously being kind of a newer one. I mentioned nebulized forms. Has anyone ever heard of this Evzio or seen this before? This one's kind of cool. This is an auto-injector, and similar to EpiPens, where a person could administer it themselves. In this case, is someone who's CNS and respiratory depressed from an opioid overdose. Are they going to be able to give themselves any medication? Typically, no, right? So you're going to have like a healthcare provider or a family member or somebody try to come along and give them one of these. And this is actually kind of cool because it actually will talk to you. So you basically pull out a tab and it'll say, okay, apply it to outer thigh, and then you apply it to the outer thigh, and then push down, hold for 1, 2. It'll count through the whole thing. It's very nice because even if you had no training prior to that, you'd at least be able to utilize the product and hopefully save a life, right? Because these drugs work very, very quickly. Has anyone ever seen naloxone given for like a reversal? What does it look like? It looks like an exorcism, yeah. So that's a bad opioid reversal. That is the most accurate way you can state it. They will go from completely comatose, needing to be intubated, to completely wide awake, vomiting, having diarrhea. They'll be very, very irritable, shaking, sweating, all these things. That's a bad one, right? You don't want to give too much because that's withdrawal, basically. We don't want to do that. The nice ones you can do, and to know you've given just enough, is when they start to yawn. Once you see this yawning sort of effect, you'll know that, okay, yeah, they're starting to wake up a little bit. And a lot of times when you're dealing with these patients in the ER, the nurses don't want them to be awake, right? You want them to be breathing. That's good. But usually if they're awake and they're withdrawing, they're a lot more difficult to deal with than not. So you'd rather just have them be nicely sleeping, but breathing. That's the important thing there. And so very important drug. Be kind of familiar with its use. But it's very fast onset, and withdrawal is really the only side effect you run into with that one. Now, we do have a few peripherally acting opioid antagonists, and so these are interesting because they don't cross the blood-brain barrier. So if I overdose like on heroin, I was comatose on the floor, giving me these wouldn't really work because they're not really doing anything to the central nervous system effects of the opioids. However, what we can actually do is use some of these for patients who have, say, utilized opioids, say like in a post-operative setting, and they're having, opioid-induced ileus, if they're not being able to pass their bowels. These are very good drugs, so they'll actually just work directly on the opioid receptors in the GI tract, wake them back up essentially, and will allow the patient to kind of recover a little bit faster and get them moving on their way. And so you'll see these sometimes used in the hospital setting more often than not, usually in the post-operative setting, to try to get patients to kind of get their guts waking up again. So you have drugs like alvimapan, methyl naltrexone, and then naloxegol, the 3 peripherally acting opioid antagonists. So for instance, if I asked a question on a test, said, you have a patient whose GCS is 3, found with a needle sticking out of their arm, you're assuming opioid overdose, this is, what drug are you going to give for this? You would say naloxone would be the drug of choice for that, not something like methyl naltrexone, because that really wouldn't work with it. They probably have diarrhea, but they're not going to wake up for you, right? You just have to intubate them. So not ideal. So just some other things you can see. So again, be very careful with the respiratory depression, the CNS depression. Those are big things, or potential killers there. Anyone know what happens with the pupils? You use opioids? Yeah, you always think pinpoint pupils. You always think meiosis that occurs with that. You're not always going to see that. In some patients, you may actually see some mydriasis. So if you think about a drug like Tramadol that has some norepinephrine reuptake inhibiting effects, you can actually see mydriasis due to that. So just because someone's coming in and they are seen as depressed, very lethargic, and they're breathing very shallowly, very slow, and you look at their pupils, just because they're not miotic does not mean that they did not overdose on an opioid. So be very careful with that. Don't use that as your kind of your gold standard diagnosis.
Tramadol the only example of that?
Tramadol's a big one, and some people just don't really get that miotic. Like, it's very rare you get that kind of really good, like, kind of prototypical sort of opioid overdose patient where they have that meiosis. And more often than not, they're either mid-range or just they don't really have that, unfortunately. It'd be nice if we could use that as like a kind of pathognomonic finding, but you just don't see that frequently, as you might think. Okay, so any questions on the opioids? How we use them, when to use them? Remember, you want good long-acting pain control for that kind of basal pain the patient's experiencing throughout the day. And then you can use stuff for immediate release products for breakthrough pain. You want to make sure you get both of those covered, because otherwise, if you don't have appropriate pain management, they're going to self-medicate, and that's where addiction is more likely to occur. Be very careful with that. Okay, so then some other adjuvant meds you might use in addition to things like opioids and whatnot. We have things that help to treat neuropathic pain. So we have a lot of things like anticonvulsants. We'll have some local anesthetics, things like lidocaine, transdermal. Anyone know the brand name for that one? I've heard of Lidoderm. It's a common one. It comes as like a transdermal patch. It will apply lidocaine locally. And we'll also got our tricyclic antidepressants. You're going to find pretty variable response with these. Not everyone's going to respond super well to, say pregabalin or Lyrica versus amitriptyline. It's hard to say which one they're really going to respond to. But we've covered most of these already, so I'm not going to go over them in super big detail. But again, reference back to the sections where they reside and look up their side effects and things like that, because it still may come up here. So some other ones we talked about: antiepileptics before, antidepressants. We'll look at some specific examples here in a minute. But here's some other things we can consider. We'll also look at capsaicin. Remember where we use that? What type of pain? Yeah, so sometimes you can use it for things like neuropathic pain, like herpetic neuralgias and things like that. But where do we use it just recently? Osteoarthritis, yeah. So we can use it for osteoarthritis. That's another big place where you're going to see it used most often. We'll talk about things like botulinum toxin. We actually were using this not too recently. I worked at Moore's yesterday, and we had a couple of kids getting Botox in the OR for migraine prophylaxis. They're actually injecting some of those neck muscles to try to loosen that up and prevent migraines. And we'll also mention marijuana here as well. So anyone who's waiting eagerly to talk about that, we'll talk about marijuana. Anyway, so some of the antiepileptics you'll see used commonly for neuropathic pain include things like carbamazepine or Tegretol. More often than not, I see things like gabapentin and pregabalin, especially for things like fibromyalgia. They got a lot of notoriety for being used for those conditions. Sometimes Lamictal or lamotrigine will be used occasionally. Again, just start low and go slow, because the primary side effect we're going to see with these medications is what? The sedation, right? So again, if they're already kind of have impaired activity due to their neuropathic pain, and now we're making them sedated on top of that, may not be a good combination. So again, start low, go slow. You can probably say that with almost anything that we talked about in pharm so far, but this goes again doubly for this. So just be aware of those side effects associated with those medications. Now, tricyclics have been used pretty frequently before as well. Again, you can't use an SSRI for this. Like, we're really looking more for some of that norepinephrine reuptaking effect in addition to a little bit of serotonin. And so the tricyclics have probably the most evidence for use, or at least history of use. Certainly, what else could we use? If we can't use SSRIs, we could use what else? Yeah, the SNRIs are going to be big here as well. So things like Cymbalta, venlafaxine, things like that are going to be good alternatives to the TCAs. Because again, if you think about a side effect profile, an SNRI versus a TCA, which one do you think has more side effects? TCAs are always going to have more side effects, right? Because you're thinking a lot more of the anticholinergic effects seen with that, a lot more CNS effects. However, some patients may respond really well to this, and so it may be a decent idea to administer these for them. Again, just remember the anticholinergic effects. Again, think about things like weight gain, sexual dysfunction. Some cases, they may be predisposed to cardiac abnormality. So just be cognizant of those sort of side effects there. You remember any specific tricyclic antidepressants? Elavil, which is amitriptyline. Pamelor, which is, I'm trying to remember, is that protriptyline? No, nortriptyline. Thank you. Yeah, that's why I always learn things by the generics, right? So there's nortriptyline, there's doxepin. Any other ones? imipramine. Those are the big ones, huh?
It's like a,
Yeah, those are the big ones. So again, those are the ones you're going to probably see most commonly. Doxepin, I don't know if I just said it. Doxepin's another big one. So those are the ones you'll commonly see as far as from a TCA standpoint. Probably amitriptyline by far and away the most common one. So the local anesthetics, we mentioned those are working well as basically blocking the sodium channel. So again, if they're preventing propagation of these action potentials, those signals never get from the site of pain back up to the CNS, never hit the spinal cord, they never hit up into the brain. And so these are sometimes used for neuropathic pain. This is where we use things like this lidoderm or those lidocaine transdermal patches. So lidocaine's a big one. We'll talk more about anesthetics in the surgery section a little bit later, but just from a pain management standpoint, we use these pretty commonly. We'll have things like Imla cream, which contains lidocaine and prilocaine. Usually if it has a cane on the end of the name, you usually know it's a local anesthetic. This one we use a lot for things like needle stick analgesia, because again, needle sticks are a big deal in pediatrics because no one likes pain, but especially kids that get very apprehensive about that. And so a lot of times we'll give them anesthetics right at the site where we want to get their IV, to let it numb them up initially, and that way it kind of helps with, to deal with the pain from that standpoint. So kind of local, kind of minor sort of procedural things can be useful with that. And then a lot of times we'll do things like epidurals or local regional blocks. These are really nice because they're opioid sparing. So if I can, if I have something like, a hip replacement or a knee replacement or something, if I can inject things like ropivacaine or bupivacaine locally right to that site, I deaden all of that sensation. I'm not getting any of that pain there. I don't have to give nearly as many opioids for that patient. I can help them to recover a little bit faster as well. So that is something you'll see very frequently, having a local blocks. We talked about epidurals being used during labor, but again, we use these in lots of types of surgeries, especially like our ortho patients. This is a very frequent thing we'll use for many of them. As far as skeletal muscle relaxants, these are going to be primarily drugs that are working on GABA, but when we talked about GABA before, we were primarily talking about seizures. We're talking about GABA A primarily. These are going to be drugs that work more on the GABA B receptors. Clinically, the only big difference here with these is that, yeah, they work as muscle relaxants, but they're also going to be very sedating. And that makes sense based on the fact that it's working through GABA. And so, again, these are all centrally acting. They're going to cause a lot of sedation, and you're going to run into the same problems you're going to run into with a lot of your antiepileptics, with your TCAs, things like that. But they can be useful in some cases. And so they kind of help with these this kind of pain, spasm, pain cycle. Are you guys familiar with that? Or basically, like, they'll tense up, they'll get pain, and then they tense up even more because of that pain. So it helps to kind of break that cycle a little bit by helping to kind of blunt that spasm that goes along with that. And so, for some patients, it's really helpful for regaining some of their motion, helps with function in general. But again, you have to really watch out for the CNS depressing effects. Start low, go slow, because they will become tolerant to that over time, and hopefully retain some of that muscle relaxing effects without being super drowsy and sedate. Right? We have drugs like baclofen, we have cyclobenzaprine or Flexeril, we have metaxalone, methocarbamol, and tizanidine. These are the most common ones you're going to run into. And again, this is one of the things we ran into from a tox standpoint, because when they had these chronic pain patients who would overdose on their meds, apparently I'm going to be kicked out of this. Oh, anyway, basically when you have these overdoses, their chronic pain patients are going to be on their opioids. They're going to be on something for their neuropathic pain, so maybe like on a gabapentin, and then maybe on a muscle relaxant like their baclofen. And we mentioned big side effects from all three of those classes. Sedation. So it's not uncommon these patients need to get intubated because they just have this overwhelming CNS depression that goes along with this. So be very careful when you're mixing and matching these meds, because you will see this kind of dose stacking sort of effect that occurs there. Actually, yeah, carisoprodol would be another one I could have added onto this this category here.
Would you say that's maybe a little less sedating than the rest of it?
Hard to say. And again, it depends on the patient, depends on what other meds are on as well. There's lots of factors that go into it. The problem with carisoprodol is it tends to, at least from my standpoint, like in the tox world, I see a lot of abuse of it. Like people will abuse it in addition to things like opioids, and they get very CNS depressed. They call it soma coma, essentially, when they come in, because they will be practically comatose. You have to intubate them, and then for whatever reason, like when soma wears off, it wears off very quickly. It takes a while to happen, but once they're out, they'll be out for like 8 hours, and they'll all of a sudden just wake right up, and the base had to be ripping out the tube. Essentially, it's very, very kind of strange. But it just depends. If you work with some of these drugs, you may find that, okay, this one's better for this type of patient because maybe it's less sedating, or this one is better for whatever reason. So, yeah. Okay, let's see. Capsaicin we talked about briefly. That's found in chili peppers and things like that. Again, very good for kind of localized pain. Not good if you need to apply it to lots of places. What's the other big education point for this drug? Wash your hands. Use gloves is the safest way to do it, right? Always use protection. Wrap it up. Your hands. Anyway. The other big thing is that you need to use it consistently because, again, you're trying to deplete substance P out of those nerves, and if I only use it sporadically, I'm going to be able to generate more of that substance P, so you need to use it consistently. If they're not going to do it, no point even trying the drug because, again, initially it's going to be very uncomfortable. It's going to be hot. It's going to sting. They need to stick with it because otherwise it's not going to be that effective for them, and they're just going to be uncomfortable, right? All right, so we mentioned did I mention this in the opioid section? Okay, so this is a good place to talk about this. So tramadol is still in the opioid category. It's a partial opioid agonist, so it's kind of wimpy from the standpoint. It's probably a little bit more potent than codeine, but not nearly as potent as something like morphine. However, for a long time, it was an uncontrolled substance, which means you could write it for kind of with impunity. But we found that, people who had a hard time getting a hold of other opioids, they would still abuse this. They could still, if you take a big enough dose, you'll still get some high out of it. And so because of that abuse that was going on with tramadol, it eventually got made into a C4. So that is now a controlled substance where it wasn't just a few years ago. But the other big thing that this has benefits for is going to be neuropathic pain because it also helps to block reuptake of norepinephrine and serotonin. So you have a little bit of opioid effect and a little bit of those kind of SNRI sort of effects mixed together, and that can be very useful for neuropathic pain. So it's a very common one. There's also a combination with acetaminophen in it called Ultraset, so you may see that being used occasionally. And again, remember with acetaminophen, what do you worry about? Hepatic toxicity, so you always have to factor in acetaminophen from all sources. They're on Percocet plus Ultraset, which would be an odd combination, but something you still may see. You need to be careful with that. Make sure you're including all sources of acetaminophen for that. Okay. Very similar opioid type side effects, but the other thing you have to consider with tramadol is some increased risk for seizures, which you can see due to the SNRI effects from that standpoint. And you will find that it's actually not kind of fully reversible with naloxone. So this is a problem when you see like tramadol overdoses. You may have to give like really big doses to try to get them where they actually start breathing on their own again, or you just may need to intubate them and let the drug kind of wear off on its own. So it can be kind of difficult from that standpoint. Okay. And then medical marijuana. Everyone's favorite. Let's just it's natural, man, right? It's safe. No side effects. It's great. Is that true? It's pretty safe. I've never seen anyone die from a pure overdose of marijuana. I can say that for sure. I've seen them get into a car wreck and die, but so it's a contributing factor. Probably not the actual cause of death. But I've certainly seen plenty of people die from opioid overdose. So there are some benefits to marijuana, but let's at least talk about where it might be have some benefits here. So the law passed back in 2016 says yes, we can use it for medical purposes. Prior to this, does anyone know what type of marijuana we could use medically? There's Charlotte's Web, which is what? So it was a strain of marijuana that was high in cannabidiol or CBD. And it was very low in THC or tetrahydrocannabinol. Tetrahydrocannabinol is the what? It's a psychoactive component of it. That's where you get the high from it, is from the THC. So if I could get a strain that was made to be high in CBD and low in THC, which was useful for what condition? Usually seizures, right? So it's like intractable seizure disorders. Some patients would greatly benefit from use of Charlotte's Web. So there's a case where we could use that for a short period of time. But now that we have medical marijuana, the law passed. And so this is an example, kind of some of the stuff defined in the law as being acceptable medical uses. And so basically they'll state, law states, the following debilitating medical conditions like cancer, epilepsy, glaucoma, HIV/AIDS, PTSD, ALS, Crohn's disease, Parkinson's disease, multiple sclerosis, and anything else you deem where there might be some benefits. So they kind of add this nice little part here at the end where it says, well, if you think the benefits may outweigh the risk, go for it, right? So it's kind of nice they left it a little bit vague there so you could potentially have some room from off-label use. It would not be against the law in those cases, right? I'm not going to get into the specifics of getting your green card and becoming a prescriber of this, but these are the things that have at least had some evidence to show that maybe medical marijuana might be useful for this, right? And so we mentioned the different components here, but the primary one we're focusing on for things like appetite stimulation or for nausea and vomiting, things like that, is mainly the THC is what we're focused on with this one. Now the two primary places that THC is going to be working are going to be the CB receptors in the brain. There's CB1 and CB2. CB1 is primarily the big thing we're going to see most of the medical uses for from a CNS standpoint. There's probably some activity in peripheral tissues for CB2, but clinically not really so important. The CB1 is what we're really kind of interested in here. And there's lots of different activities on different neurotransmitters, but just leave it to say if you need to know the mechanism for marijuana, it acts on the CB1 receptors. And that's going to be kind of the extent that we need to know it. So what are the risks? What are some side effects from marijuana utilization? Sedation, you might see some mild sedation. Okay. What else? Some people may get nauseous, but again, one of the things we'll use it for is for nausea and vomiting, especially like chemotherapy-related nausea, vomiting. We'll talk about a little bit about it in the GI section, but there's actual like synthetic marijuana we've been using for quite some time for chemotherapy-related nausea and vomiting. So they're called Marinol or Dronabinol is one we've used for quite some time now. What other things might you expect to see? Hunger, right? So you can see weight gain associated with that, right? You get the munchies. I sound like such a nerd when I say that. Man. Anyway. Okay, so what else? What's a big one that may be like potentially deadly? Motor impairment, right? CNS motor impairment. What happens to your judgment when you're on marijuana? Not great, right? Usually you're making worse decisions than you would be otherwise, typically. So again, people get behind the wheel of a car and they can be just as impaired as if they were drinking alcohol. So that's the big thing you have to worry about. And again, that's why you say, when you get arrested for something like this, is driving while impaired, right? Not necessarily under the influence of alcohol or one thing or the other, but if you pure impaired, like that's where they get into trouble. So be very careful from that standpoint. Chronically, we don't know all of the effects, right? Because it's hard to do studies. Because federally, what is marijuana still scheduled? Still a Schedule 1 substance federally, so it's been very difficult to actually do the studies. And it's actually kind of interesting because I was looking at some documentaries and things, and they were saying that the one place where basically all of the marijuana is being used for research uses was coming out of like one university that was growing it. And said it was actually a pretty poor strain of it where the THC levels were not great, and so they were actually finding that maybe the studies they've done already maybe weren't actually using the right appropriate stuff, and maybe could have found better effects. Who's to say? But that's one of the things you'll find. It's very difficult to do research with marijuana from that standpoint. Now, what are some different ways you can use marijuana? You guys don't have to pretend like you don't know, because I'm not gonna like narc out on you guys or anything. I don't know. What does one use a marijuana? We're all friends here. We're all friends here. So you can smoke it, right? So what are some problems with smoking marijuana? Damage to the lung. It burns, right? Anytime you're having that hot gas coming into your lungs, it can damage the cilia there. You can definitely see chronic lung issues from smoking marijuana. So that is definitely a documented effect. You can see just like with cigarettes, right? So we know there is some inherent risk with that. What are some other routes? Yeah, so they're edible, right? So again, THC is typically very lipophilic, right? So it goes well into different like oils and things like that. That's why you can see it used in a lot of cooking applications, like brownies and things like that, because it will partition into fat very well, like butter and oil and things like that. So that's why you see usually like in more kind of rich sort of foods. Now, there's a problem with edible formulations of marijuana. Anyone know what it is? It goes back to pharmacokinetics. It takes a while to kick in, right? So again, think about if you inhale a drug. We mentioned that when you inhale a drug, what's kind of the pathway for it to be absorbed to the brain? It goes from the lungs to the heart, back to the brain, right? So very, very quick, very fast onset versus orally. It has to go through the GI tract, has to be absorbed, has to go through the liver, then it gets to the bloodstream, to the heart, then eventually to the brain. So the onset is much, much slower. And then what you're finding in some of these cases, especially in places where marijuana has been decriminalized, is you're finding that patients who are using edible formulations, they don't understand that it takes time. It can take like 90 minutes to 2 hours before it to really kind of like kick in orally. So what they're doing is they'll take it, they'll have like a brownie or something or some edible form. They'll wait 30 minutes and say, like, I'm not feeling anything. Guess what they do at that point? They take some more, right? So they get impatient, they take some more, and then they're like 30 minutes later, still nothing. Guess what? It takes some more. So then they get very, very high all at once. And this is, we've seen some increased calls to, admittance to the ER due to these patients who are kind of just overwhelmingly high, and they get, there's certainly some negative psychoactive effects that can occur. There's kind of paranoia that can go along with it. So there's some drawbacks to it, but be very careful if they're doing it edibly. You need to know it's going to have a slower onset of action than you would see if you were inhaling it. Now, from the inhaled standpoint, you know, I don't know necessarily. There's a lot of studies looking at, you know, if you're like vaping it versus actually like smoking it. Again, you think with the vaping solution usually being a lot cooler, you'll probably see less damage done overall. So I imagine that's probably overall a safer method for patients to use it if they had to. So one thing to consider there. Okay, so let's see. So that's mainly the kind of the negative effects associated with that. You know, chronically, who knows what the actual long-term effects are going to be? Is marijuana addictive? Maybe. Okay, so it's one of those things where like physically not as addictive as something like an opioid, right? You don't get the same kind of physical dependence on marijuana as you do opioids, right? So that's probably not up for debate. That's pretty well understood. However, there's probably a psychological kind of dependence that comes around that, especially if you're like have, you know, it's part of your social standing. If that's like all your friends are doing it, you're more likely to do it as well. Things like that, where there might be some degree of dependence, but not nearly as addictive as you would see with like an opioid, right? So that is one clear benefit to using this over other more addictive sort of substances. So there's a good meta-analysis. I'll post this up. I forgot to do that, but there's one done back in 2015 where they were looking at different randomized controlled trials. I'm not trying to give you guys PTSD from EpiBio, which you could take medical marijuana for at this point, we've established. But randomized controlled trials that were looking at different things like, you know, nausea, vomiting, chemotherapy. They're looking at it for spasticity due to MS and all these different conditions. And basically what they found was there's some modest improvements. There's modest, you know, benefits and symptoms. However, not really a slam dunk. There's nothing that says by far and away marijuana is a way to go for any one of these conditions. But it could have some benefits. So in general, should you start with this? Probably not. It's probably one of those things that could be used as like a second or third line agent, especially if your patient is, you know, especially, you know, really kind of gung ho for it. Try other things first. Try other things that may have a lot more evidence or history of use behind it, and then you can use this as kind of a backup for that. So these are some of the recommendations from JAMA in 2015, where, you know, not necessarily guidelines, but these are the recommendations of this group. They're saying that basically the way you should decide whether or not a patient would be a good candidate was if they're having one of these debilitating medical conditions where there is randomized controlled trials to suggest as a positive effect. Again, we're not just going off case studies or you know, cohort studies or things. We want randomized controlled trials. Why do we want that? The best level of evidence we can have, right? We're much more likely to be able to draw actual causation from those trials than you could just correlations with seeing like in a cohort study, right? So because of that, I say, okay, randomized controlled trials has a positive effect. We feel very comfortable saying that yes, there's probably some benefit there. And if they failed first and second line agents, this is a good backup. And that they failed other FDA-approved cannabinoid products. So we'll mention that in the GI section, but there's things like dronabinol, nabilone. These are basically synthetic products that kind of act like THC. Try those as well, right? Those are prescription based. You don't have to worry about some of the harmful effects, especially like smoking and things like that. Those are worth a try as well. And then they need to have no active substance abuse issues, psychotic disorders, unstable mood, or anxiety. Try to get those under control first, and then you can consider using that. So I think those are pretty good, you know, conservative guidelines to not give it to everyone. However, there's probably some subset of patients who are good candidates for this. So any questions on medical marijuana? I'm totally a square, so I have no experience with it myself, but some patients do very well with it. I was like a nerdy fat kid growing up, so like that was not my social circle basically of like Nintendo, PlayStation, and me. Like it just wasn't, never really entered into it. But anywho, all right. So pain management, very complex. We have lots of options that are out there. Not one thing is going to work for every single patient because everyone's pain is very unique. Everyone's pain is very subjective, and so you need to treat it as such. Again, education is super important. Make sure they know what their goals are, know what they should be looking for as far as side effects go, know what constitutes reasons for changing from one med to another. And again, help them to manage the side effects based on, you know, if it's opioid-induced constipation. There are things we can do for that. We don't have to just let them be constipated from here on out, right? We can do things to manage that. So, any questions on the pain management side of things? All right. So one of the other big things you run into from an orthopedic standpoint is venous thromboembolism. Why do you think this is a problem?
People aren't mobile. They have orthopedic injury.
Yeah, so either orthopedic injury or if they have orthopedic surgery done, like have a knee replacement or hip replacement, they're usually immobile after the surgery, right? And so this is a problem because when you're kind of sedentary like that, what can happen? You get blood pools on the venous side. They can form clots, and then we can basically get from the DVTs you can get form into Yeah, pulmonary embolisms. Those are big things. We're kind of talking about this kind of continuum of disease for right here. And these are all going to be drugs we've already talked about previously. So we're mainly talking about ways to prevent it and then actually treat it. So it should be pretty familiar based on some of the other anticoagulant talks we've already had before. So again, we know it's potentially fatal, and those people that are at really big risk are going to be hospitalized patients, and especially those who have had kind of major surgeries, especially like the lower limbs, especially of an orthopedic nature. These are the big ones, especially if they have any kind of hypercoagulable state kind of prior to that, right? So it's always a big thing to consider there. Now again, DVT themselves are rarely fatal, but the PEs are the things we need to really worry about from that standpoint. So again, just looking at different risk factors, some of these we can modify, some of these are not going to be modifiable for us, right? So we can't change the age of our patient. However, we can try to do things about things like venous stasis. So like in a post-op setting, what could we do to try to help to eliminate some of that stasis there?
SCDs.
Yeah, so SCDs, which stands for sequential compression devices. Yep, so that's one thing we can do. Not STDs, but SCDs, right? You don't want to give those to your patients. Someone asked me the other day, like, don't you drive an STD? I'm like, it's an STI, but it's not much better, but close enough. Anyway, that's one way you can do it, right? So those basically kind of have the sequential compression devices where basically they'll kind of have a hooked up to a pump that will kind of compress different parts of the leg kind of in a sequential fashion to try to help eliminate some of that venous stasis that happens there. Anything else we can do? Stockings, yep. So compression stockings are one way we can do that. Okay, so we'll get to the drugs in a second. But good thinking. Unfractionated heparin is one we use there. Ambulation, yeah, get them up moving around, right? This is why we wanted to do things like, make sure their opioids are not trying to stop all their guts and they're really sedate from having all these opioids on board, because that helps to impair them from getting up and moving around. Like that's what we need to do is early ambulation. Not always possible, but we try to do it as best we can for these patients. But the way I ran into it a lot of times was in like the medical ICU. We'd have patients who are intubated and sedated for weeks, months potentially, and so we needed to use things like anticoagulants to try to keep them, try to prevent that from clotting up. We'd use SCDs very frequently. These are things where, the patient were not able to ambulate on their own, and we had to help kind of manage that. And of course, we know estrogen-containing therapy can be one of our big causes for drug-induced thromboembolism. Okay. So again, we know what's happening here. Basically, your platelets are starting to, while the blood's being very, not moving around very much, it's very static. You have these platelets kind of forming a thrombus. We'll have eventual activation of our clotting factors, and this is where the fibrin eventually will turn from fibrinogen into fibrin and kind of stabilize that clot, right? So most of our drugs we're going to focus on are going to be working on which kind of pathway here. You're not going to see a whole lot of antiplatelet use necessarily, but we're going to be working a lot on the clotting factors, and we're going to be working potentially, especially if they're in a life-threatening sort of state, potentially on getting rid of that fibrin, right? Anyone remember what we used to get rid of that fibrin? TPA, so tissue plasminogen activator. Plasminogen is that protein when it gets converted into plasmin, helps to degrade that fibrin into soluble products, and it'll help to break that clot. Those are your clot-busting drugs, and TPA is the most common one we use for that. So anyway, so again, review back to your Pharm 1 slides, so we'll talk about these briefly here, but things like side effects you worry about with some of these drugs, these are things you want to kind of review and at least be aware of. So, like I mentioned, compression devices, physical activity are very good for helping these patients to prevent the clots from happening in the first place. However, if they're at higher risk, or they cannot ambulate, or they cannot use, especially if they had like a trauma or something like that, and they could not use a sequential compression device, these are things where our drugs are going to be very useful here. So mainly we're going to focus on the heparin side of things. And remember how heparin works? Works with antithrombin 3, and it helps to, what does the antithrombin 3 do? Breaks down those circulating factors, right? So remember, like factor 2 and 10 are some of the big ones we're going to be focusing on. We also have things like 9, 11, 12 also get affected on the heparin side of things. A little bit different flavor than you would see with like warfarin, but again, with warfarin, that's only dealing with the production of new clotting factors. With the heparin, we're dealing with clotting factors that have already been made. So these are going to have much more immediate onset of effect because they're going to work with antithrombin 3 to eliminate those clotting factors and break them down much more quickly. So we can do things like unfractionated heparin. We can give that subcutaneously, and so you may see that where it's being given as like 5,000 units every 8 hours, and that is as a prophylaxis to prevent the clots from actually happening in the first place. We then have enoxaparin, which is what classification does that fit under? Yeah, it's a low molecular weight heparin. So remember how its activity shifts between that and unfractionated? Yeah, it's just more towards 10. You'll have some too, but mostly 10 is the main thing you're focusing on there. And you have drugs like fondaparinux, which is? It's a Rixtra. only works on 10. Remember, it's even shorter than the low molecular weight heparins, and that only works on factor 10. Any of these are very good options for prophylaxis of clots in these high-risk patients. We can use things like enoxaparin just once a day, and so it's a little bit nicer from that standpoint. You can use it subcutaneously for 1 shot a day rather than having 3 shots in a day, which a lot of patients would prefer that in a lot of cases. So typically, what you'll end up seeing for postoperative management, especially with some of the procedures that are more prone to VTE than others, like kind of lower limb procedures and things like that, they may require anywhere between 10 and 14 days of therapy for prevention, right? So, and again, the earlier you can get them up and walking around, the better, the shorter that is going to be, and you can get them off that a little bit sooner. Again, this is generally preferred whenever possible. So basically, if you did have a VTE actually occur, though, so again, what are some signs you could see that you're having like a DVT? So DVT specifically.
Swelling.
Yeah, sweat, unilateral swelling, that palpable cord, redness, a lot of pain associated with, right? So if you actually confirm that, yes, there is a VTE happening here, you decide kind of whether or not anticoagulation is contraindicated or not. So again, a lot of patients it will not be. However, if it is, if there are a big risk, then basically you can use something like a vena cava filter that will kind of just sit right there in the vena cava and will prevent those clots from getting to the heart, essentially. So that is one way you can do that. But focusing on the drugs, let's say, for instance, we have our PE diagnosed. If they are having like an active, like really kind of life-threatening PE, if they're very unstable, that's when we're going to focus more on our clot-busting sort of drugs. Like your TPA, you're going to administer emergently to try to lyse that very, very quickly. It's nice for things like stroke where you can kind of have a little bit more targeted application because you can kind of find right where that occlusion is pretty easily for those ischemic strokes. However, for PEs, you don't really have that option quite as much, or if there is, it's not done very commonly. So you usually have to use kind of systemic TPA. And what's the big risk with TPA? Bleeding, right? So you can actually have a hemorrhagic stroke. You can have bleed out kind of elsewhere. So you got to be very careful with TPA. Make sure you're giving at the appropriate dose. And the dose changes between if it's an MI versus PE versus stroke. So you got to make sure you're looking at that beforehand and make sure they're not having any risk factors that preclude them from getting it. For instance, if they had history of recent bleed or something like that, it would make it inappropriate to give them that because they're just too high risk for bleeding. However, then you would kind of move down and consider, okay, what else is kind of going on here? If they are having a PE, they're not really unstable at that point. This is where we consider things like treatment doses of either heparin, which usually heparin is very kind of short acting. You have to give the heparin drip. And you guys remember how we monitor for heparin effect? APTT, right? So you're going to measure, basically give them a bolus of heparin, try to start inactivating those clotting factors, and you monitor their APTT. Usually it's like 2.5 times their normal APTT. You try to get them up to, and that shows that they're at an anticoagulated level, essentially. It's a continuous drip. Versus like enoxaparin, we can actually give it as twice daily dosing. Again, you can either do that IV or subcutaneously, and that also is kind of your treatment dosing. Dosing is much higher, typically for treatment, than you see with prophylaxis. So that's one big difference you'll see there. So anyway, consider thrombolytic therapy if it's kind of more serious condition, but otherwise, we talk about unfractionated heparin, low molecular weight heparins. Now, keep in mind, some patients are actually, what we're starting to see is more of these new oral anticoagulant agents. You remember we talked about like rivaroxaban, apixaban, dabigatran, all these kind of newer oral agents. And I've actually seen some studies where they're saying like, well, instead of having a patient say if they come in from the outside, so say they're on estrogen therapy and they come in with chest pain, they get diagnosed with a PE, instead of putting them on heparin and then transitioning over to warfarin, they're actually just going directly and starting to use things like Eliquis, which is apixaban, or using something like dabigatran, directly in the ER, which is kind of interesting because instead of them having to get IV therapy for several days, they can go straight to oral, which is kind of a novel approach in a lot of cases. But a lot of times if they do have a documented clot, you need to keep them anticoagulated for a period of time after that. So usually you'll transition them over to something like rivaroxaban or warfarin for 3 months. And then if you've kind of dealt with the problem, or if it was kind of a reversible problem like into surgery, or if they're on estrogen therapy and you've got them off of that, then you don't need to worry about that anymore. However, if it was, they had a hypercoagulable state that was, congenital or something like that, you may need to be on that for longer, right? So those are things to consider. Just remember, if you have an acute clot, usually heparins are going to be the thing to jump to. If they're unstable, life-threatening state, then this is where your clot busters like TPA are going to kick in. Any questions on that? I think that's all of it for the ortho section. I'll talk more about sedative agents because, again, the other thing we did a lot for a lot of our ortho cases that were coming into the ER, so especially like fractures and things like that, we had to use a lot of sedative agents, and I'll talk about that more in the surgery section. So that'll be coming up later, probably in the ER section as well. Any questions so far? Okay, if not, we'll go 10-minute break and come back and we'll start our GI section.